What if the very thing you fear most about your mind is not decline at all, but distortion? What if the memory lapses that unsettle you, the names that slip away mid-sentence, the sudden difficulty concentrating after 40 or 50, are not the first whispers of irreversible dementia, but signals from a brain under chemical strain? In clinics across the country, countless adults confront this terrifying uncertainty. They notice slower thinking, diminished focus, or a subtle erosion of mental sharpness, and the immediate assumption is early Alzheimer's disease. The anxiety that follows can be overwhelming. Yet the truth is more complex, and in many cases, more hopeful. Cognitive impairment is not always neurodegenerative in origin. Alcohol, sedatives, sleep medications, and even certain prescribed drugs can significantly impair executive function, attention, processing speed, and short-term memory. The prefrontal cortex, responsible for judgment and impulse control, and the hippocampus, essential for memory consolidation, are especially vulnerable to chronic chemical exposure. When these regions are repeatedly bathed in substances that alter dopamine, GABA, and glutamate signaling, the brain adapts in ways that may reduce clarity and resilience. As addiction psychiatrist Anna Lembke has emphasized in her work at Stanford University, modern life often normalizes substance use while underestimating its cognitive cost. Alcohol in particular is frequently minimized because it is socially sanctioned, yet sustained consumption can shrink neural networks involved in planning and memory. Benzodiazepines, often prescribed for anxiety or sleep, dampen central nervous system activity through GABA enhancement, which can slow information processing and impair recall. Sleep medications may induce unconsciousness without restoring the deep, slow-wave cycles necessary for true neurological repair. Over time, the cumulative effect resembles early dementia, but the underlying mechanism is pharmacological rather than degenerative. This distinction is not academic, it is life-altering. Neurodegenerative disorders, such as Alzheimer's disease, follow progressive trajectories marked by accumulating neuronal damage. Substance-induced cognitive impairment, however, may partially or even substantially improve with sustained abstinence and medical supervision. The difference between irreversible pathology and reversible toxicity can hinge on an accurate evaluation. Midlife itself introduces vulnerability. Hormonal changes, metabolic shifts, vascular health, and stress exposure create a landscape where the brain's adaptive capacity narrows. In that context, substances exert amplified effects. A drink that once felt harmless may now interfere with synaptic plasticity. A medication once tolerated may now fragment attention. The brain is not failing, it is responding. Understanding this response requires disciplined assessment rather than catastrophic assumption. Structured medical evaluation, cognitive testing, laboratory screening, and honest disclosure of substance intake are essential steps. Without them, symptoms are misattributed, treatment is delayed, and fear multiplies. The message is neither to deny the reality of dementia, nor to minimize legitimate neurological disease. It is to recognize that not all cognitive changes are destiny. Some are feedback. Some are signals that the brain is overburdened by chemical inputs. It was never designed to process chronically. The critical question is not simply, am I losing my mind? But rather, what variables are influencing my brain today? That shift in inquiry transforms panic into investigation, and investigation into possibility. The unsettling part is that the brain rarely announces the true source of its distress. It whispers through fatigue, through subtle indecision, through the growing reliance on reminders and lists, and those whispers can be misinterpreted as the early tremors of irreversible decline. Suspense builds in that ambiguity. You may sit alone at night, wondering whether the trajectory has already begun, whether something inside your skull is quietly deteriorating beyond repair. Yet beneath that fear lies a more intricate neurobiological story. Alcohol and sedatives do not merely relax you. They recalibrate neurotransmission. They suppress glutamate, the primary excitatory neurotransmitter responsible for learning and synaptic strengthening. They amplify GABA, the inhibitory signal that slows neural firing. Initially, this produces calm, sedation, and relief. Over time, however, the brain compensates. Dopamine pathways adjust downward, reward thresholds rise, and cognitive efficiency diminishes. What once felt like relief becomes a subtle drain on mental energy. Executive function falters, processing speed slows. Short-term memory fragments. These effects can mimic early dementia so convincingly that even highly educated individuals assume the worst. This is where the clinical distinction becomes urgent. Neurodegenerative conditions follow patterns of steady progression, often with structural brain changes visible on imaging and characteristic deficits on neuropsychological testing. Substance-related impairment, in contrast, frequently presents with fluctuating performance, disproportionate executive dysfunction, and a history of chemical exposure that aligns temporally with symptom onset. The tragedy is that many people never examine that timeline carefully. They normalize nightly drinking. They continue long-term benzodiazepine prescriptions without reassessment. They increase sleep medications rather than questioning why restorative sleep is elusive. Meanwhile, the prefrontal cortex struggles under persistent neurochemical modulation, and the hippocampus receives inadequate opportunity for synaptic repair. The suspense intensifies because the longer this pattern persists, the more entrenched it becomes. Chronic exposure may accelerate biological aging processes, including oxidative stress and inflammatory cascades within vulnerable neural tissue. Midlife compounds the vulnerability. Vascular stiffness, metabolic syndrome, and hormonal transitions reduce the brain's resilience. Under these conditions, even moderate substance use can exert disproportionate cognitive consequences. The frightening question emerges: what if the symptoms improve? What if abstinence, medical supervision, nutritional optimization, and structured sleep hygiene produce measurable cognitive recovery? That possibility challenges the narrative of inevitability. It suggests that some decline is not destiny, but adaptation. In clinical addiction psychiatry, including the work of Dr. Anna Lembke, emphasis is placed on recognizing how reward circuitry becomes dysregulated through chronic overstimulation. When dopamine spikes repeatedly from external substances, baseline motivation and clarity can decline. Individuals then consume more in an attempt to feel normal, perpetuating a cycle that further clouds cognition. The suspense is not whether the brain can change. Neuroplasticity persists throughout life. The suspense is whether intervention occurs early enough to reverse functional impairment before structural damage accumulates. Differentiating between degenerative disease and substance-induced impairment requires disciplined evaluation, comprehensive history-taking, medication review, laboratory analysis, cognitive testing, and sometimes neuroimaging. It requires courage to confront patterns that have become habitual. But within that confrontation lies a powerful realization. The brain is dynamic. It responds to what you feed it, chemically and behaviorally. And sometimes the most frightening symptoms are signals inviting recalibration rather than surrender. The most powerful shift occurs when fear gives way to responsibility, because responsibility restores agency. If cognitive symptoms may be influenced by substances, then intervention is not an act of desperation, but of precision. Protecting brain health begins with intellectual honesty about intake patterns, quantifying alcohol consumption without minimization, reviewing every prescription and over-the-counter sedative, and evaluating cumulative exposure over years rather than weeks creates a clear baseline. From there, structured change becomes possible. Sustained abstinence, or medically supervised tapering, allows neurotransmitter systems to recalibrate. Dopamine receptors gradually regain sensitivity. Glutamate and GABA signaling re-establish equilibrium. Sleep architecture can normalize, restoring slow-wave cycles essential for hippocampal memory consolidation. This process requires patience because the brain heals incrementally, not instantly. During recalibration, individuals may experience transient anxiety, irritability, or mental fog, which can be misinterpreted as further decline. In reality, this period often reflects neuroactive reversal. Clinical monitoring is critical. A structured medical evaluation, including laboratory screening for metabolic factors, thyroid function, vitamin deficiencies, and inflammatory markers, helps rule out additional contributors. Neuropsychological testing provides objective benchmarks, allowing measurable comparison after weeks or months of abstinence. When improvement is documented, motivation strengthens. When deficits persist, further diagnostic exploration can proceed without assumption. This disciplined approach prevents catastrophic thinking and replaces it with data. Evidence-based strategies extend beyond substance reduction. Cardiovascular exercise increases cerebral blood flow and supports neurogenesis within the hippocampus. Resistance training improves insulin sensitivity, indirectly protecting neuronal integrity. Cognitive training, when combined with physical movement and restorative sleep, enhances synaptic plasticity. Nutritional interventions emphasizing omega-3 fatty acids, phytonutrients, and glycemic stability reduce oxidative stress. Stress modulation through mindfulness or structured breathing attenuates cortisol exposure, which otherwise impairs memory circuits over time. Each of these interventions reinforces the principle that the brain remains biologically responsive well into midlife and beyond. The narrative that all memory lapses signal inevitable dementia is not only inaccurate, it is disempowering. Distinguishing neurodegenerative disease from substance-related impairment allows targeted action. Neurodegeneration demands specialized neurological care, long-term planning, and disease-modifying strategies where available. Substance-induced cognitive impairment demands behavioral modification, medical oversight, and sustained abstinence. Conflating the two delays appropriate treatment and magnifies anxiety. The disciplined path forward requires courage to confront habits, willingness to undergo evaluation, and commitment to longitudinal monitoring. It requires abandoning stigma and embracing science. The brain is neither fragile glass nor invincible steel. It is adaptive tissue shaped continuously by exposure and behavior. Midlife vulnerability does not equate to permanent decline. It signals a narrower margin for error and a greater need for intentional living. When individuals choose recalibration over resignation, they often discover that clarity returns gradually, attention sharpens, and memory stabilizes. That recovery is not accidental. It reflects biological principles operating as designed. Understanding the distinction between cognitive decline and substance effects transforms fear into informed action. It replaces assumption with assessment and despair with disciplined intervention. If you're benefiting from our topics, please subscribe, like, and turn on the bell notification so you can see our new videos early.